Hi guys, I'm back again, and this time I'm talking about our very last chapter, disorders, and that is chapter 14. In chapter 14, we're going to talk about two different kinds of disorders, mood disorders and schizophrenia. Here are our objectives. We're going to start by explaining the symptoms and biological causes of major depression. Then we're going to describe some of the antidepressant treatments, then talk about bipolar disorder, then go on to schizophrenia. So objective one, let's just go ahead and get started. We'll explain the symptoms and biological causes of major depression. Well, you probably already know something about major depression because if you took abnormal psychology or even intro to psych, you know something about major depression. But here are just some of the symptoms. Basically, people just have a really hard time having a good time. They feel helpless, they feel hopeless, they feel worthless. A lot of times they have suicidal thoughts. A lot of times it manifests itself behaviorally in sleeping too much, or crying a lot and things like that. And it has to go on, in order to get the diagnosis of major depression, it has to go on every day for 2 full weeks. Okay, let's talk a little bit about the genetics of major depression. It's going to run in families, so there is definitely a genetic effect. But the genetics are stronger for that early onset version of it, just like we've seen before for Alzheimer's disease and Parkinson's disease. That early onset version, alcoholism as well, by the way, before age 30 tends to be more genetically related. Probably there are some genetic alterations that go on that, combined with stressful experiences, brings out the depression. But you've got to have the stressful experiences as well. So environment is quite possibly very heavily involved there. Okay, well, hormones are also certainly probably involved, and we know that because childhood depression does not have a gender difference. So just as many kids who are male get depression than who are female. But right around puberty, we start getting a pretty massive gender difference there. And that difference is that women are much more likely to get depressed. So we start seeing a lot of depression in adolescent girls compared to adolescent boys. We also note that hormones, well, of course, there are big hormonal changes in adolescence, but there are also hormonal changes postpartum, meaning after a woman has a baby. And that's another place where women are very prone to get depression. About 20% will report depression after having a baby. And that has to do possibly with that sudden drop of estrogen and progesterone, the birth of the placenta. You're going to get rid of a lot of progesterone, and then you're not cycling, so you don't have, typically you're not cycling if you're breastfeeding, and so you don't have the estrogen either. Another thing that we imagine that hormones are involved is testosterone. Men who, sometimes older men will get low testosterone, and that gives them a tendency toward depression as well. So clearly there are some hormonal influences. Another possible influence is hemispheric asymmetry, meaning that the two hemispheres, again, are not the same. We know that low activity in the left prefrontal cortex and in the left hemisphere in general is going to tend to result in depression. And we've seen that before with people who get strokes in the left hemisphere. They tend to be more depressed. Once the right hemisphere takes over, the right hemisphere has sort of got some of those negative emotions tied up in it. So people with left hemisphere damage in general become depressed. One of the things you can tell is whether you gaze to the right or you gaze to the left when you're thinking about something. If you gaze to the left, then you tend to be right hemisphere dominant, and those people tend to get depressed. And so the right hemisphere, if the right hemisphere is dominant, that tends to give you more proneness toward depression. That's just one way of looking at it. Okay, let's talk about objective 2, some of the antidepressant treatments. What do we do for depression drug-wise? Well, there are 3 drugs that are pretty common. One is the SSRIs, and this is clearly the most common use of drug for depression. And those are things like Paxil, Prozac, Zoloft is another one. And it's SSRI because it stands for selective serotonin reuptake inhibitor. It's selective to serotonin, serotonin only. It blocks the reuptake, and therefore is a serotonin agonist. It increases the amount of serotonin. There's not really too bad of side effects. It's not addictive. It doesn't have a lot of problems. But about 30 to 60% will get a sexual dysfunction. They might find it hard to become sexually excited, but more likely they're going to find it hard to have an orgasm. So while that seems like, oh wow, I wouldn't want that, if you're really, really depressed, you're probably not having too many orgasms anyway, if you know what I mean. So at any rate, but sometimes that's something that keeps people from taking it as well. So the SNRIs are serotonin norepinephrine reuptake inhibitors, and they block both serotonin and norepinephrine. That's what the N stands for. They block the reuptake there, so they're going to bring up the quantities of both of those neurotransmitters. And some examples of those are Cymbalta, Effexor. And, you know, for some people, those work better. You know, I mean, just if the SSRI doesn't work, then they usually try those. And the atypical, if neither of those work, then, you know, they might try an atypical. Atypicals tend to inhibit the reuptake of dopamine and norepinephrine, but not serotonin, so they don't work on serotonin. So if the person is having particular problems with those sexual side effects, they might try an atypical, but more likely, just if the others aren't working, they just keep trying. So these two are the older drugs, and they are not you just don't see those as much anymore. The tricyclics will block the reuptake of dopamine, norepinephrine, and serotonin, but there are just a lot of terrible side effects. They do everything because they work on so many different neurotransmitters. The side effects will include all kinds of sleepiness, you can't pee, you got a dry mouth, it's just awful. Lots of heart rate irregularities and stuff like that. Same with the MAOIs, or monoamine oxidase inhibitors. There's an enzyme that metabolizes or breaks down serotonin, norepinephrine, and dopamine. It's called monoamine oxidase. And if you inhibit that, then you're going to increase the amounts of those neurotransmitters because it can't get broken down. But again, we have a lot of side effects there. One is the cheese effect, which is that you get this interaction if you eat cheese, and all of a sudden your blood pressure shoots up. And you've probably seen do not take with MAOIs on a pill bottle. You almost can't take any other medication with it. So those aren't used very much anymore because of that. Okay, well, let's talk a little bit about drugs and the physiology of depression, because there are some issues there. If we look at serotonin level in people who are depressed, the serotonin level is normal, norepinephrine is normal, dopamine is normal. So you're asking something like, well, why is bringing up the levels of these neurotransmitters, why does that affect depression? And so that is a big confusing thing. You know, nobody really knows why, because it's not like there's an abnormality in the level to begin with. So another problem is that the drugs will immediately block the reuptake. So for example, if you're on an SSRI, as soon as you take it within 4 hours, you've got more serotonin. However, the effects of the drug, the antidepressant effects, take 2 or 3 weeks to take place. So you're like, what's going on? Obviously, it's not the increase in serotonin, which happens immediately if it takes 2 or 3 weeks for the drugs to work. Now, for mild and moderate depression, these drugs don't work any better than a placebo. So there are a lot of people who are on it for mild and moderate depression, but unless you've got serious, you know, major depression, it's really a placebo effect. The reality is we don't know why these drugs work. But there are a couple of possibilities that people have talked about. For example, release of neurotropins, because we do get a release of neurotropins, and particularly in the hippocampus. One of those is called BDNF. There may be also, there's evidence of neurogenesis in the hippocampus when you're taking these drugs, that they may cause the generation of new neurons, and that may be an effect. But you know, the truth is, we just don't know why these drugs work. We don't know why they work, but they do work for serious depression. But again, not for mild to moderate. All right, let's talk about some other possibilities here. Some alternatives are psychotherapy. Psychotherapy is great. It's really, really good. It's got about the same effectiveness of drugs, and you see similar brain changes. For example, with psychotherapy, we see increases in serotonin. it is even more effective if you combine it with drugs. So if you go to a therapist and also get the drugs. And certainly with the psychotherapy, we are less likely to relapse because the person is learning some things that cognitively they can do to control the depression in the future, where drugs don't give you that. St. John's wort is a herbal alternative to these drugs, but it works very similar to the SSRI, so it increases serotonin. But there are some problems with it. You can use it, you can buy it at Walgreens or whatever over the counter, but it does reduce the effectiveness of birth control and other medications, so you should caution their using it. Exercise is very effective against depression. A brisk 30-minute walk or jog 3 times a week is effective, and it's as effective as the SSRIs. Light therapy is also very effective, or bright light in the morning, and particularly blue wavelength lights in the morning. Not just for seasonal affective disorder anymore, we're using it for all kinds of depression, postpartum depression, and everything. Okay, one final treatment for depression is called ECT, or electroconvulsive therapy. And that is basically shocking the brain using electrical shock. And to do this, they do use informed consent. It's a very kind of like last resort sort of treatment. If a person is very suicidal, it does work pretty immediately, which is nice, unlike some of the drugs. They apply it every other day for 2 weeks. There is a memory loss side effects, and because of that, they often only apply to the right hemisphere, which, remember, is our kind of more depressed hemisphere, and then we get fewer memory problems if they only shock the right hemisphere. About 80% will recover from the depression, but about half of those are going to relapse while depression comes back. Surprise, surprise. It tends to be that way no matter what you do. We don't know why it works. Again, it was just kind of by accident that we figured it out. Maybe it increases neurogenesis in the hippocampus. Possibly that could be the effect there. Okay, finally, I want to talk about treatments based on sleep. Depressed people tend to have sleep problems. They tend to sleep too much. They tend to sleep at weird times. One of the treatments we can use, or people don't use very much, but they can use, and it works, is to try to go to sleep earlier. So maybe go to sleep at like 5 o'clock in the afternoon and then wake up at, say, midnight or something like that. That helps to get in line with the circadian cycle, and it is effective, at least in the short term, at treating depression. Staying awake all night is also effective, like just go 24 hours no sleep at all, still sleep the next night, but it tends to throw people out of depression. Again, those are effective for short term if they're not used very much. But it just shows that sleep really does have to do with depression. We'll talk about bipolar disorder next time. Thank you for listening, and have a great day.